who will talk to us about understanding the population-level impact of mass vaccination campaigns against cholera in the DRC. Judith, can you hear us?
Yes, now I can hear you. Thank you.
All right, I'll hand it over to you.
Perfect, thanks a lot. I'm very happy that today I can tell you about this project on understanding the population-level impact of mass vaccination against cholera in Uvira in the Democratic Republic of Congo. Uvira is a city of around 300,000 inhabitants located in the east of Congo between the mountains and Lake Tanganyika. And this area provides the unique opportunity to study the impact of vaccination campaigns because of the wealth of data that is available here for many years now. And I will highlight this during my presentation today. So since the end of the 20th century, oral cholera vaccines have been available and have been used in outbreak and endemic settings. And at an individual level, we understand quite well how effective they are. And they are initially very effective, but this effect wanes relatively rapidly over time. However, for the population level impact, we have much less information, where this is actually very important if we want to guide public health measures, and also if we want to inform optimal vaccination strategies. So for other infectious diseases, we have seen a rapid decline of cases after the initial introduction of the vaccine, such as, for instance, here for measles in the US. However, such clear evidence for cholera vaccination is currently still lacking. And one reason is that often vaccination campaigns are applied in epidemics when the number of cases is already declining, such as this example in Malawi. And afterwards, the situation is only observed for a relatively short period of time. And one exception is this study from Quadri et al., where they looked at two areas where they applied vaccination and compared it to an area of no vaccination. And they actually found quite a large reduction of cholera cases in the two vaccinated areas in Bangladesh, where cholera is endemic as well. And based on a very simple theoretical evaluation of the herd immunity threshold, we can get an idea of the expected vaccine impact based on the basic reproduction number of an infectious disease. And this simple theory tells us that for an infectious disease with basic reproduction numbers, as were estimated for cholera, we would need up to 60% coverage for a perfect vaccine to reach herd immunity. And if we correct that for the estimated vaccine effectiveness, this would go up to around 80%. And in Uvira, the estimated vaccine coverage 11 months after the mass vaccination campaign in 2020, the estimated vaccine coverage was 55%. So based on this simple theory and also on modeling results that have been published before, we would expect quite a reduction of cases in this situation. And after the vaccination campaign in Uvira in 2020, we actually see indeed an initial reduction of cases, but this was followed by a relatively large outbreak by the end of 2021. And afterwards, we observe persistent transmission. And another vaccination campaign was done by the end of 2023. And afterwards, we don't see the initial reduction that was observed after the vaccination campaign in 2020. So this illustrates that the transmission dynamics in the endemic setting of cholera in Uvira is much more complicated than we could simply explain by the simple herd immunity threshold theory. And the aim of our study is to better understand the vaccination impact in Uvira after the mass vaccination campaign in 2020. And our first objective is to estimate this impact for this specific situation and also to describe the changes in transmission dynamics of cholera after the vaccination campaign in Uvira. And these objectives require mathematical modeling, but we can only do good mathematical models if we have adequate and high quality data available. And the unique setting in Uvira provides exactly these data that we can use for building relatively complex models. So in 2016, Rapid Diagnostic Testing Center was built in Uvira, and a long time series of systematic acute watery diarrhea testing was done to get this nice time series of actually positive cholera cases, which is quite unique in the cholera research because many other epidemiologists in other areas have to rely on the total number of acute watery diarrhea cases reported only. Additionally, there were also 3 survey studies that were done after the vaccination campaign, which collect data on vaccine coverage and also the healthcare seeking behavior of individuals. And the households that participated in these studies were selected using remote sensing data to ensure representativeness of the study. And 2 of the survey rounds also include serological data. So altogether, these data are really providing a unique opportunity for mathematical modeling. So we have the systematic testing data over a long time series. Then we have the representative survey data, including vaccine coverage and health-seeking behavior. And we have the serological data that we can use to understand the asymptomatic infections. Past cholera modeling have mostly focused on modeling single epidemic curves. And these are relatively easy to fit with simple models. However, when you go to more endemic situations, it becomes more complicated. And the endemic modeling of cholera has mostly focused on Haiti and Bangladesh. And for Haiti, it was safe to assume that the initial population was completely susceptible to cholera infection, which made it possible to fit the initial dynamics of the epidemic relatively well. However, for both Haiti and Bangladesh, it's more complicated to fit models to the endemic and seasonal trends. And we hypothesized that one reason for this could be that most of the models assume a single recovered compartment for individuals after their infection, which is independent on the severity of the infection. And also the individuals in these recovered compartments are completely protected against reinfection, and they have waning over time. And theoretical considerations have shown that the dynamics of the model can be very different if we include multiple immune compartments, and also if we allow for different kind of immune dynamics. And we think that a leaky immunity is the most biologically realistic to include in the model. So based on these considerations, we have identified several key model features that need to be included for realistic modeling. First is a time-varying transmission rate that incorporates all transmission dynamics, also the ones that we don't explicitly model. Then we have multiple immune compartments, and within these immune compartments, we allow for leaky immunity. And additionally, we also model the observation process to correct for imperfect testing and changes in healthcare seeking behavior. So this is the model state that we're currently working with, and I just want to highlight 2 of these model features, where first is the different immune compartments. So we have a different compartment after asymptomatic infection with shorter duration of immunity compared to the immunity after a symptomatic infection. And additionally, individuals after waning of their immunity, they don't return to the completely susceptible state, but instead they go to the S' compartment where they're still slightly protected against reinfection. And then each of these different immune compartments have a different level of leaky immunity. Then we can use the wealth of data to actually calibrate our model. So first of all, we use the vaccine coverage data to calibrate the population dynamics, which includes birth and deaths, but also migration dynamics. Additionally, we can use the zero prevalence data to get an idea of the fraction of asymptomatic infections. Then there's also some parameters that we want to estimate with our model. These include, of course, the time-varying transmission rate, the duration of the immunity in the immune compartments, and also the leakiness within these compartments, and the initial condition on all of the compartments that we model. We then evaluate the model in a Bayesian language called STAN in R. And within this framework, we given a set of parameters, we solve the ODE system that describes the compartmental dynamics I showed you before. And in combination with the solved ODE system and the observation process that includes the health-seeking behavior and a correction for imperfect testing, we get an incidence curve of observed cholera cases, and we independently model an incidence curve for non-cholera cases. And taking both of these incidence curves together, we can calculate the likelihood for observing the total number of acute watery diarrhea cases and the total number of positive cholera tests. And with this likelihood within an MCMC framework, we can then sample from the posterior distribution of the parameters we want to estimate. And all of this is included in a Bayesian workflow where we first use simulated data to make sure our model works correctly. And we can use also simulated data to identify any requirements for priors and for identifiability issues of the parameters. We then use iterative model updating to check that our model can correctly describe the observed data. And once we are happy with our model, we can generate a counterfactual scenario without vaccination and compare these two scenarios to estimate the impact of the vaccination campaign in 2020. And currently, we're still in the process of iterative model updating. So this is a plot of the validation of our model with simulated data. So in red, you see the simulated number of total acute watery diarrhea cases. And in orange, you see the 95 credible interval, which is the output of our model fit. And in pink, you see the total number of positive cholera tests, which is a function of the total number of tests that was performed for each week. And then in blue, you see the fit outcome of our model. So with this simulated data set, we can show that actually we can infer the parameters that we're interested in if we have enough information on the priors. And then I can also show a preliminary fit of the observed data where the coloring is the same as for the simulated data. And you can see that we are getting close to the actual observed dynamics, but we're still think that we can update our model and get a better fit to the data. But we're quite positive that soon we will be able to estimate the impact of the vaccination campaign with these models. So with this presentation, I hope I convince you that predicting the population level impact of cholera vaccination is complex, especially in endemic settings, but that we really can do a lot with all of the data that is available for Uvira in the DRC, and that this can also help us to provide a framework to improve the impact in the future. And we think that relatively complex models are necessary, which include various leaky immune compartments to accurately describe the transmission dynamics. And with that, I would like to thank all the people that work on the project and the funding and you for your attention. And I'm happy to take any questions.
Thank you, Judith. Great talk. Do we have any questions? We have a moment for a few.
Thank you for the nice talk. I might have missed it, but what sort of data are you using to inform like changes in care-seeking behavior over time, like especially like the impact of the potential impact of the COVID pandemic in 2020 and making that more complicated to estimate the effects of the vaccination campaigns?
Thank you for that question. Yeah, so the information on the healthcare seeking behavior that we have is coming from these survey surveys, these 3 survey rounds that were done after the vaccination campaign in 2020. So you can see here in blue the timing of these surveys. So I think it would be difficult that based on these data, we can make a really good inference about the impact of the COVID pandemic, because we don't have any pre-pandemic survey data. Yeah, so we really only have these 3 surveys.
Any other questions for Judith? I can chime in with one. I was curious. I noticed in some of your earlier slides, you had plotted the decay in vaccine effectiveness, and it looked like there were quite large confidence intervals around that. And I was wondering, is that factored in at all while you're fitting your model, or had you considered doing any sensitivity analyses to look at any uncertainty around effectiveness?
That's a very good point. So no, so far I didn't include any uncertainty in the efficacy. Also, there's a difference between the efficacy for 1 dose and 2 dose vaccinations. So that would really have to go into a next round of our model to include these uncertainties. Yeah, that's a good point. Thank you.
Oh, Jillian, please. Here I can probably.
Thanks so much for the presentation. I was just wondering what the, for the test negative case counts in this chart, what is the explanation for that? Is that a different pathogen or a test sensitivity issue, or what explains that?
Yeah, so that's most likely another pathogen that is causing acute diarrhea as well. Yeah. So for the test sensitivity and specificity, we can correct because we know the number of tests that we're doing and we know quite well the sensitivity and the specificity. But in this area, there's also a lot of other pathogen types that we have to correct.
Excellent. Okay, if there are no more questions, then if you will join me in thanking Judith for a great presentation.